So the 10 questions that people have asked me: are there good tests that tell me if I'm infected by COVID-19? I have scleroderma. What can I expect if I get COVID-19? If I had COVID-19, can I get it again? And if I get vaccinated, will my scleroderma flare? And what can decrease my response to vaccination? Next slide. Then, very importantly, which of my medications interfere with the vaccination? And is there anything I can do about it? Omicron. Is Omicron really more infectious? And if true, why is that? And what about long COVID? And then one practical issue, which has to do with masks. Next slide. First, are there good tests to tell me if I'm infected by COVID-19? Next slide. Well, you can see here that there have been 21, at least, RT-PCR tests. Those are the really good tests. And you can see that they're pretty good. Their sensitivity and their specificity, which means positive if you have COVID-19 and negative if you don't, are really more than 90%. Next slide. But there's more to it than that. First of all, you've all heard about the saliva tests, or the mouth oral pharyngeal test, and the nasal test, which we're used to. Which one is better? This looked at in a laboratory doing both. And these were in people who had antibodies. And so we know they had the disease and responded to it. And you can see on the right there what's called the PPV and the NPV. The PPV is better than the sensitivity and specificity. It's the positive predictive value. It tells you the accuracy of the test. And NPV is negative predictive value, the accuracy when it's negative. And you can see here comparing the nasal swab, which is the gold standard, versus saliva, that they're really very, very good, that the saliva test is darn near as good as the nasal test. And they agree more than 99% of the time. However, there's a problem here. These weren't done in real life. These were done in a lab. And if you think about it, if someone's doing it at home and they put a swab into their mouth, it depends how long they do it, where they do it, whether they do it on both sides, whether it's someone who's used to doing it, how long you swab, whether you're doing it with a child or an adult. So at the end of the day, although in the laboratory, the saliva test is as good as the nasal test, really, the saliva test is usually not quite as good. Excuse me. Next slide, please. So what about the rapid antigen test? You know, that's the one that's been sent around to everybody's home and which can be used. If you look at the NPV and the PPV that's been highlighted there, you can see that whether it's patients without symptoms in red or who had symptoms in that ugly brown, that it was really very good if it was negative, 92 to 99%. So a negative test is very accurate, but when you look at the positive predictive value, it really is a whole lot less good. Somewhere between the two of them, about 65, 70%. So what you need to do is realize that if you get an antigen test, which is the one in 15 minutes, and it's negative, that's pretty good. If it's positive, however, you have two choices. One, do it again, because done twice, it'll tell you something. But ultimately, you'll need to go and do a PCR if it's positive to know that it's really positive. Next slide. One way of telling is to get a blood test for antibody response to COVID. So if you get vaccinated, the antibodies should be developed in your blood, and you can take a blood test and see if you responded. But look it up in the upper right corner there. You see that it takes 21 days till it really does. You can be sure that your body has produced the antibodies. So in fact, during the first 3 weeks, if you get an antibody test after vaccination, it doesn't tell you much. You have to wait about 3 or maybe even 4 weeks. And then it'll tell you accurately whether your body has responded to the vaccination. Next slide. So with respect to testing, the PCR is the gold standard. The rapid antigen test is very good if negative, but it's not good enough if positive. The nasal and saliva tests may both be good if done perfectly, but the oropharyngeal is not probably good enough in usual practice. And then if you want to know if your vaccine worked, you have to wait at least 3 weeks after the vaccination. Next slide, please. Next question. I have scleroderma. What can I expect if I get COVID-19? Next slide. This looking at the whole medical literature, and they looked at nearly 3,000 articles, and of those found 60 which looked at prevalence data and 65 that looked at clinical outcomes. And what you can see on the left there in blue is that the odds ratio for getting COVID-19 is 1.6. So what does that mean? If your odds ratio is 2, it means you have twice as high a probability of getting it. So for patients with rheumatic diseases, and some of them had scleroderma, but not all of these patients had scleroderma, the possibility of getting COVID-19 is increased by a factor of 1.6. And if you get it, how dangerous is it? Well, you look on the right, and it says the odds ratio of death is 0.5. Well, that sounds like it's less. It isn't really because of the technique here, but what it does say is that the odds ratio of dying if a patient with autoimmune disease gets COVID, it's not greater than in the normal population. Okay, so getting the disease is higher probability, but dying from it is not compared to the normal population. Next slide. There was another study which looked at about 2,400 patients with autoimmune rheumatic diseases versus controls. And you can see on the left that most of these patients had RA or lupus, and a small proportion had scleroderma. And on the right, you can see that most of the patients were on steroids or drugs like methotrexate or mycophenolate, etc. Next slide. If you look at them, what you see here, and this looked at the outcome in this group of patients. And what they meant by outcome was hospitalization or admission to ICU or requiring intubation and mechanical ventilation, or if the kidneys failed or there was a stroke or thromboses or death. In other words, really bad disease. And if you looked at that as the outcome, it turns out that whether or not these patients were on background DMARDs like Cellcept or Actemra or whatever, it did not seem to make an increased probability of having these bad outcomes. But if they used steroids, there was an increased probability of having a bad outcome. So if you're on steroids at home, this increases the probability of getting in trouble if you get COVID. Next slide. So what are the things that seem to predict if someone's going to get in trouble? This looked at hospitalization in patients with rheumatic diseases, so whether they ended up in hospital or not. And the things that predicted hospitalization were on the right. And it's not surprised that older people had a higher probability of getting hospitalized. By the way, if you look on the left, you can see the kind of autoimmune rheumatic disease patients that were there. And there were very few scleroderma patients, but a lot of autoimmune diseases. So other things that predicted hospitalization if you got COVID was high blood pressure, having lung disease of any sort, diabetes. So having other complications, not surprisingly, makes it more dangerous to have COVID. What was interesting was on the right there. You see that the odds ratio of getting in trouble if you use more than 10 milligrams of prednisone a day was 2. In other words, if you were taking prednisone more than 10 a day at home, it's really puts you at greater risk of needing hospitalization if you get COVID-19. What's also interesting is if you are on other drugs, in other words, controlling your disease, like with mycophenolate and stuff, that decreased the probability of you actually ending up in the hospital. Next slide. So if you get it, is it more likely to be more severe? Well, this was only in patients with lupus, RA, or psoriasis, but it was a huge database. Look at this, 17 million adults. And they looked at the lupus, RA, and PSA patients. And they looked at the odds ratio, another word for hazard ratio, of dying if they had an autoimmune disease. And it was increased by about 20% compared to the general population. So for these illnesses, it was more severe if they got it. Now, this isn't a perfect study. For example, they didn't look at background medications. They didn't look how active the disease was. They didn't look whether people were smoking or not. Nevertheless, it says that you got to watch out. If you have COVID, it can be a lot worse than if you did not have this scleroderma. Next slide. So what were the predictors of COVID-19 bad outcome, mortality? Well, this is odds ratio again. Remember what it means. If you're older, that's not a good sign. If you are a man, if you had chronic lung disease, if you had other comorbidities like hypertension, or again, if you are on prednisone more than 10 milligrams a day, that predisposed to dying from COVID-19 if you get it. Gives people a handle on what they have to watch out for. If they have chronic lung disease, that puts them at greater risk of dying. Again, saying that if you get COVID-19 and have lung disease, you're more likely to be in trouble. These aren't new, but they're really good new data. Next slide, please. There was one study looking at COVID-19 in scleroderma patients. This was in about 200 patients, and they looked at whether the patient required hospitalization, oxygen, ventilation, or died. Follow-up was only for about 1.5 months. What they found was that in scleroderma patients, COVID-19 was severe in 24% of them, and that 12% died. Now, in the normal population, it's 9% death. So it isn't much increase in death rate. And then about 10% got long COVID. And on the right, you can see the predictors. If you had other diseases, we talked about that, hypertension, diabetes, etc. If you were older, and surprisingly, if you had kidney disease, those are predictors of bad outcomes. Next slide. So if you look at it, what can you expect if you have scleroderma? First of all, I didn't have a chance to show you this, but only about 3% of patients with autoimmune disease get COVID. So it's not a high prevalence, but there is an increased risk as well as increased severity in patients with autoimmune diseases, AID. If you're taking more than 10 milligrams of prednisone a day, that confers an increased risk. If you have other comorbidities, such as diabetes, etc., bad lung disease, that confers an increased risk. And age, being a male, having lung problems or kidney problems make it more likely to get in trouble. Next slide. So, if you've had COVID-19, are you going to get it again? Next slide. This looked at a large study in Italy. And what you can see is that the infection rate was about 5%. And the reinfection rate was well under 1%. So getting reinfected is really pretty rare in this study. Next slide. Here they looked at UK workers, 12,000 people. And you can see that a positive culture occurred in the next year in 1.7% and symptomatic infection in 0.3%. So again, only 0.7% of patients converted over the next 6 months after having COVID-19. Very low percentage. Next slide. This was a good study out of Israel. They looked at 1,500 healthcare workers who got the Pfizer, and they did some very nice control work covering the controls. And they looked at the appearance of antibodies after vaccination. And what they found, there was 2.6% of the patients developed this afterwards. And it was about a month or so after the completion of the vaccination. Now, this is only 2 vaccinations, no boosters. You'll see on the right that most of these sources of that revaccination was in people who were unvaccinated. And that 57% of those were household contacts. What was good was that all of the patients had only mild disease or even no symptoms at all. Next slide. So how long does the protection last? In other words, how long after the vaccination did breakthrough infections occur? Now, this was only after 2 doses, right? But you can see here, looking out to 5 months after the initial one, this is either Pfizer or Moderna, and the outcome was whether the PCR was positive. And you can see here that the Pfizer was a little less good at preventing long-term reinfection than the Moderna, with about 2.8 per 1,000 patient days versus 1.6. So that comes down to 0.16% or 0.28% at 5 months. Very rare, isn't it? Next slide. So at the worst, breakthrough infections occur in up to 2.6% of vaccinated persons, and it mostly comes from household contacts who were not vaccinated. Next slide. Well, what about vaccines? Next slide. The question came up was, if I get vaccinated, will my scleroderma flare? After all, we're putting a foreign protein in, and our bodies are primed to have a response, an autoimmune response to foreign protein. So what happens? Next slide. This looked at about 600 patients. And we don't have the data for vaccinations for COVID-19, but we do have it for shingles. And the incidence after vaccination of having recurrent zoster or shingles was 0.6%. Very low there, but very low. What was interesting was if they looked at the various drugs people were on, the only drug that was associated with an increased incidence was our friend corticosteroids. Next slide. Some people said, well, wait, I never had this disease until I got vaccinated, and then I got it. So how often does that occur? This looks at the literature, and you can see there are various vaccines like hepatitis B or influenza or tetanus or a vaccine against Guillain-Barré or rabies. And what you see on the right is it was extremely rare. For example, after hepatitis B, there were some cases of SLE, but from 1970 to now, only 25 cases were listed. And if you look at the bottom of this slide, you see something about incidence. Basically, a new disease after a vaccination occurred somewhere in the range of 2 to 6 per million patients. I guess it happens, but boy, it's got to be rare. Next slide. So flare seems to be only in those on steroids, although we don't know the dose. And the incidence of causing the disease, if true, is a few per million. Next slide. So we get vaccinated. What's going to make my response to vaccination less, i.e., decrease how protected I am once I get vaccinated? Next slide. So this looks at Pfizer and Moderna, and it looks at 30 to 40,000 patients. Protection or efficacy of the vaccine wasn't very well defined, but if you look at it, you can see on the right, there's protection greater than 4 months, and a lot of times it was 8 months. It was very good after the Moderna, 92%. Still very good, but not as good after the Pfizer, 84%. So for at least 4 months and probably 8 months, it's pretty good protection. Next slide. Now this looked at 3,500 hospital workers at Hopkins. And what happened here was they looked at patients who had been infected before getting vaccinated and then got them vaccinated after they recovered. And you can see in the blue line that if you got infected and then got vaccinated with 2 doses of the mRNA, Pfizer or Moderna, in other words, getting 3 doses, right? The COVID was their first dose, and then the vaccination was doses 2 and 3. At now 210 days, about 7 months, protection was at least still 80%. However, if you didn't get infected beforehand, in other words, just 2 doses, by the time 6 months had rolled around, protection was only about 40%. So that the 3rd dose, in a weird way of saying it, really seems to make a difference and keeps you protected at least to the 80% level for at least 6 months. Next slide. Now, this is a little bit more like what many of you have. These are patients who've had kidney transplants. And of course, you haven't had kidney transplants, but all of these patients are immunosuppressed. And this looked at 160 patients. They all did not have any response in terms of antibody after 2 doses of the Mrna. And then they were given a 3rd dose. And the antibody was measured about 2 months later. And 50% of them responded to the 3rd dose. So even though they were so immunosuppressed that they didn't have any antibody response after their first 2 doses, they still had about a 50% response after the 3rd dose. That's very reassuring. It says that most of you, no, all of you should have gotten 3 doses. Next slide. So what it is the duration of time since your last vaccination, and some of the medications, like the immunosuppressive meds for kidney transplant patients, can decrease the response. And we'll get more into the medications later. Next slide. So, which of my medications interfere with the efficacy of the vaccine? And if I have that, what can I do about it? Next slide. This looks at the immunogenicity of the Pfizer vaccine. In other words, how good it is. And you can see on the left, medications like Actemra or Plaquenil or Enbrel really did not interfere with the vaccination at all. These were patients, as you see on the upper part there, who had various autoimmune diseases, no scleroderma patients. But once they were on methotrexate, there was a slight interference, about 8% lower. And JAK inhibitors like Xeljanz also had a slight decrease in efficacy of the vaccine. Once you got to the steroids, you see it was 23% for the steroids. For Cellcept, it was 36% decrease. For Orencia, 38%. And then drugs like rituximab, 60% decreased response. Next slide. So if there is a decreased response, and you've been on one of these immunosuppressants, is the disease, COVID-19, more severe? This looks at rituximab. Now, it looked at 400 patients, and only 1% of them, 0.9%, had severe disease. Okay? And in those patients, if they were on rituximab, they had a 2.3 times higher probability of having severe disease, odds ratio of 2.3. So if patients are on rituximab, they may have more severe disease if they get COVID-19. Next slide. This looks at a whole bunch of things. First of all, on the bottom, Orencia, rituximab, Actemra, Xeljanz, Enbrel, or Humira. Those are the different colors. And here they look at various aspects of severity. Whether they were hospitalized or not, didn't make a difference which drug you were on. However, if you required oxygen, then there was a much higher probability if the person was on rituximab, and somewhat higher probability if they were on Xeljanz or drugs like that. There's even a hint that Orencia. In terms of deaths, however, the probability of dying was highest for rituximab and much lower for anything else. Next slide. What about good old corticosteroids? Well, we've been saying this all along, but this is another study, and what it showed was if a person was on more than 10 milligrams of prednisone a day, they had a 2 times higher probability of getting severe disease. Now, there's just some odds and ends here that you have to be aware of. One, this isn't in our usual diseases. This is an autoimmune disease such as Crohn's disease or ulcerative colitis. 2, they didn't define severe, but it does bring home the point that greater than 10 milligrams of prednisone a day is associated with more problems. Next slide. So in terms of the medications that interfere with the ability of the vaccines to do their job, corticosteroids, rituximab, and the rituximab-like drugs, probably Cellcept, and possibly Xeljanz can decrease the response to vaccination. Next slide. So we've learned this. What can we do about it? Next slide. First of all, we can talk about vaccination, which of course is important. Next slide. One of the things that really has come out is that 3 doses of vaccination, that is the 2 plus a booster, are better than 2 doses. Here you see this looking at a huge number of patients. This was 300,000 Israeli healthcare workers, okay? And on the right, you can see the percent reduction in probability of developing a positive RT-PCR after 3 versus 2 doses. And after 3 doses, the probability is reduced by about 85%. So that, and this is by about 2 or 3 weeks. So you can see that that 3rd dose really makes a difference in the probability of getting a positive PCR, which is, of course, COVID. Next slide. Now, that study didn't tell us anything about symptoms, but this looks at symptoms, and for the first time in today, it talks about Omicron. It looked at 13,000 patients who got Omicron, 10,000 who got the Delta variant, and 47,000 controls. And they compared 3 versus 2 or 3 versus no vaccination. And the symptoms were self-reported symptoms. And the vaccine was self-reported vaccination. So it can't be absolutely sure. But if you look at this, this is the relative risk of getting symptomatic Omicron in blue if you had 3 versus 2 doses. And what it says is that after 3 doses, the risk is decreased by 67% or 66%. So that it does help against Omicron as well, not just Delta. Next slide. Now we have to take a step back. This gets a little more complicated. When we think about the immune system, we think about white blood cells called lymphocytes, and they're broken down into various types. One is called the B lymphocyte or B cell, and it produces the antibodies that we measure in the blood. Another kind are called T cells, and they have various things they do, but they basically are cells in the tissues that kill the virus directly. Okay, so there are B cells with antibodies and T cells in the tissues. Next slide. What this looked at was the 3rd vaccine dose, but looking at it when someone changed from one kind of vaccine to another kind of vaccine. And these are the Wuhan on the left, which is the original, then Alpha, is B117, Delta is B1351, and P1, and I don't know what that one is. I don't know which one that is. But you can see here that if you look at the bottom, you see the thing that says CHAD or CHAD and then BNT or CHAD to CHAD. So let's look at the Delta one, the 351. You can see that CHAD alone gets you that kind of antibodies, B cell response. If you give it twice, it doesn't change it very much. But if you go over there a little bit and see that when you give the CHAD and then you give the Pfizer, all of a sudden, there's a much better antibody response. Now switch to the right, where the T cells are. Now, this is not something we always measure. We should, but it's very much more complicated. And this reflects the T cell response in the tissues. So even if there aren't any antibodies, there may be some response in the tissues, which is kind of hopeful. It means that even if you don't get antibodies, you may still have some protection. And here you see the response measured as something called interferon gamma. It's just a way of measuring how T cells respond. And you can see that if it goes from CHAD alone to CHAD plus Pfizer, there's a marked increase in response. So changing the booster from, let's say, Pfizer to Mrna when you're going to the 2 and then adding the 3rd dose, or vice versa, Mrna to Pfizer, really is very helpful for increasing your body's immune response and protecting you better. Next slide. So how much is protection? What's the antibody level that counts? This looks at that. What you see here is in purple, it says non-cases. And it looks at the response at 29 days. And compared to cases, and on the y-axis, the vertical axis, you see it says 10, 1, 10, 2, etc. That's logarithmic. So 10, 1 means 10. 10, 2 is 10 times 10 or 100. 10, 3 is 1,000, etc. And in the patients where there were cases, the antibody response was less than 10. And in the non-cases, it was somewhere above 10, somewhere closer to 100. Then if you look on the right side, you can see that at 2 months, if the response is somewhere around 500, you don't get any cases. You see that 100% protection at the top. So it looks as if you have an antibody response between 100 and 500, you're well protected. Next slide. So now we know about that. What do we do about it? What are the treatments other than vaccination? Next slide. Well, there are a lot of them, which is great, right? If you look on the left, you can see that some of them were proven to be ineffective, others probably ineffective, and a few probably effective, but not yet fully proven, including baricitinib, which is like Xeljanz. On the right are the ones that have been proven to be effective. And I'm not going to go through all of them. We certainly don't have time for that. But I am going to pick a few of them. I'm not going to talk about Actemra because everybody knows that for severe disease, it really works. Okay, next slide. What about this corticosteroid stuff? I hate corticosteroids, and I really do. And now we're told they're one of the best drugs for COVID-19. What's going on? Next slide. This looks at all the reasonably good studies looking at the use of corticosteroids for COVID-19. And on the right, you can see in yellow, steroids, DEXA, that's the equivalent of 30 milligrams of prednisone a day for 10 days. And on the right, standard therapy of all sorts without corticosteroids. And you can see that there's a lower incidence of death when using DEXA in hospitalized patients who are sick, and lower probability of requiring ventilation, and higher probability, although not statistical, of mild or moderate disease. And on the right, it shows the same thing. So it says that in severe cases, using higher dose steroids for 10 days is helpful. That's in contrast to using lower doses, like a little bit more than 10 milligrams a day, chronically on an outpatient basis, which increases the risk. Okay, so high dose corticosteroids when you're sick and in hospital, low dose corticosteroids, not such a good idea. Next slide. I also want to look at these three things: molnupiravir and Paxlovid. These are two tablets. They're given for 5 days if you get positive PCR and some symptoms, but very early, the first 3 to 5 days. These, in essence, are to cut off the problem at the pass. If you get symptoms and are positive, these are the ones to try. Are there data to support that? And then sotrovimab, I get this one wrong all the time. Sotrovimab, I think. And that's an antibody. Next slide. NIH has kind of summarized this. Paxlovid is one of the oral tablets. Molnupiravir is the other oral tablet. And sotrovimab is the one that's given IV. And you can see here, NNT. That stands for number needed to treat to prevent or treat a disease. And you can see that for Paxlovid and sotrovimab, it's about 17 people. And for molnupiravir, it's 35. It's half as good. But look at it from the bottom. You can see that the mortality is prevented with Paxlovid, nearly prevented with molnupiravir, and prevented for the sotrovimab. Can't get it right. So that it looks like these tablets are really good to use if you have very early disease. It's one of those things where you might ask your doctor, can I have some of it sitting at home in case I get it? But you shouldn't use it if you don't have the disease. Next slide. Well, what about using antibodies given IV? This is one of them. And you can see on the right that using a single dose of this IV antibody, you get rid of the virus. You get rid of 99.97% of the virus. Pretty darn good. And if you look at the study on the left, the red line is the placebo group, the blue line, the patients given the antibody, and you can see that the response is earlier and more if given the antibody. In other words, it works. Next slide. What about Omicron per se? Next slide. So first of all, is it really more infectious? And then why? Next slide. This comes from the New York Times. And you can see on the left how infectious it was. It got way higher than any of the previous waves. And it went away very quickly. For hospitalization, same story, not quite as marked, but still more hospitalizations and some more deaths, not a lot. Next slide. So it really is true that it's very much more infectious. Well, this looked at the 3 or now 4 different waves of COVID-19. The first one in yellow is the original. The orange one is alpha. The brownish one is delta. And the dark orange one is Omicron. So if you look at that, you can see that Omicron is associated with lower requirement for oxygen, fewer deaths, and lower ICU admissions. Really looks milder, doesn't it? So it's clearly more infectious and milder. Next slide. So why did this happen? What you're doing, looking on the right here, is the picture as if you were looking directly down on top of the spike. And in the lower left, the C, where it says ACE2, that's the receptor on the cell. And it's where the SARS-CoV-2 attaches to the cell to get in there, the infectivity. On the right lower, D, you see that yellow, that's the only mutation that was found in that area with the alpha. Won't really interfere with its ability to get into the cell, to attach. The delta has 2 mutations, still not much of an effect. Look at Omicron. How many mutations right at the place where it would attach to the cell? What that means is it doesn't attach as well. In fact, it's not as infective, at least not through this receptor. There's another one in which it does. So in fact, Omicron is less infective. It doesn't get in the cell as well. But because of that, when the body produces antibodies, or if you're vaccinated and the body produces antibodies, those antibodies can't attach as well to block the virus. Okay, so what you've got here is decreased infectivity, but decreased ability to stop the virus. So it's a balance. And what happens overall is the virus can't get in, but it can reproduce like mad because it isn't being gotten rid of. And the end result of that is there's so many more viruses around, they get in. And the antibodies produced by the vaccines, because of all these mutations, aren't as good. And that's why you get this rapid increase in the infection. But it's milder because they don't get in as much. Next slide. What about long COVID? Next slide. This is a 6-month follow-up. And what you see here is that patients who at 6 months after COVID, 23% of them were still anxious and depressed. 60% of them still felt weak. 26% had poor sleep. And there was mild decrease in renal function, although it wasn't particularly important. What predicted the getting of long COVID is if during COVID, the patient was anxious and depressed, was very fatigued and weak, and if their lungs were in problem. That is, if their CT of the lung was worse, or if their ability to take oxygen out of the air, the DLCO was worse. Next slide. Another way of looking at this was in this 400 patient study. And what you see here is that at 7 months, really 8 months most of the time, some symptoms still occurred in 40% of patients. And they were mostly fatigue, occasional loss of taste, shortness of breath, and headache. All sorts of other things also occurred, like joint pains and rashes, poor memory, but much less frequently. Next slide. So what can you do about it? Well, this looked at 900 patients who had long COVID symptoms, and these were all self-reported problems. And they were given an additional vaccination, a fourth vaccination. And 57% of them improved after the fourth vaccination. So it looked like another vaccination made a difference for the long COVID patients. Next slide. And then there was a drug, amitriptyline. It's used for fibromyalgia. It's used for depression, which turned out to block the ability of the virus to get into the cell. It affects something called sphingomyelinase. Not very important, but it says that amitriptyline may help people who continue to have symptoms. Next slide. And in this actual study, they looked at fluvoxamine. That's an SSRI, like Paxil or Zoloft, things of that sort. And you can see that in those patients who had the disease, using fluvoxamine prevented deterioration in all cases compared to placebo, without a great increase in side effects on the right. So that it looks like using an SSRI like fluvoxamine and probably things like Zoloft, etc., may help prevent deterioration. Hasn't been actually used in long COVID, but it can be extended to that. Next slide. So for long COVID, about up to 40% of people still have symptoms at half a year. A fourth booster helps in about half of these patients. And some drugs may also help. Next slide. So our last issue is practical issues, and it really has to do with masking. Next slide. This was a very interesting study, only in 7 people, and they used various kinds of masks. You can see them here. There was an N95. There was something called KN95. That was from China. And then there were various cloths like cotton and stretch and stuff like that, all used. And what happened was they examined the number of particles that are kept outside versus inside the mask. In other words, how good it is at preventing particles from getting in. And the particle sizes that were used encompassed the size of the SARS-CoV-2 virus. Next slide. They looked at it in a number of ways, and we'll get to that in a minute, I think. But one of the things they found out was that sometimes when things look like they fit, they don't. Here's 2 people in whom both looked like it fit very well, looking head on. But when you looked at underneath at the neck, in one case, there was enough tissue under there to form a seal, and in the other, there was not. Next slide. And here's what happened. They did the study in 2 ways. One, they did 1.5 minutes each of just sitting, of nodding, either yes or no, of reading aloud, or of walking. That's part A. And part B, they looked at 3 hours of normal activity. And they looked at the ratio of particles that are kept outside versus inside the mask. And what you can see here on the left is if you use some sort of tea towel or something like a surgical mask or the N95. And I can tell you the KN95 looked more like the surgical mask than anything else. It was very clear that the protection factor was about 100 times greater, well, maybe 25 times greater for the N95 than either of the others. That's on the left. And on the right, if you look at the protection factor after 3 hours of normal activity, it wasn't quite as impressive. It was about 5 to 10 times as high. But still, the N95 really worked compared to the other. There was no testing of the double masking or some of the things we do, so we don't know. But we do know that if something fits well, including under the chin, that'll work. Now, how can you tell? Well, you can tell because when you breathe in, if you're well fitted, you'll get a retraction of the mask. It'll pull in towards you. Next slide. So with that, come on, inner peace. I don't have all day. I want to thank you for your attention, and let's go and deal with some questions, okay?
Thank you, Dr. Furst. A lot of great information.
Okay.
I have some questions that were sent to me prior, and I'm going to go with those first, and then I'm going to start reading the ones in the chat box, okay?
Okay.
First, I have ILD, so my questions are regarding my own masking, which I assume will last quite a while. And when can I go into a theater or on a plane again?
So what's the exact question?
I guess when it comes to masking, I guess it's not completely clear.
Okay, so I think
When
what you're
can I
trying
go
to say,
into a theater or on a plane again? But it did say that this is regarding my own masking, so I'm not sure how to tie the two in.
right? So I'm going to extrapolate here a little bit. If you're using a mask that fits well, you have as good protection as you can. Personally, using 2 masks, you know, some of those that fit, and then a regular surgical mask may help protect you. When is it safe to go into an airplane? Well, depends on your risk factors. If you have bad lung disease, you better be careful until this thing's under control. Okay?
Thank you.
I think that's probably as close as I can get. Go ahead.
Thank you. I had 3rd vaccination booster in August of 2021. Is it time to get another?
So this gets into the 4th booster question. It's a big question, and I'm going to go into the area of data-free advice. In other words, we don't have good data for this. We can say that long COVID seems to respond about half of the time to a 4th booster. We can say that in Israel and the CDC, they recommend a 4th booster. By the way, when checked on what data Israel and the CDC depended for this 4th booster recommendation, they said, we have no data. So the data aren't there. There's no question about it. Having said that, based on everything I talked to you about before, the 5 to 7 months, et cetera, I think a 4th booster at 5 to 7 months makes sense. Without the data, mind you, okay?
Thank
And
you.
without proof that it works, except for the long COVID. But if you do, I would recommend trying to get one that is different than the one you had before.
Thank you. So I think this sort of answers the next question about how safe the boosters are. But the next question that came with that was, what about the vaccination safety for children between 12 and 17?
Okay, so first of all, the side effects. As those of you who are my patients know, I always say you never get something for nothing. So you always have to pay attention to that. Now, what is the something and the nothing? The vaccine is very protective. What's the downside? Well, you get all sorts of side effects, right? You get a sore muscle. You might get a rash. You might have a little fever. You might have a day or two of tiredness. Those are certainly real. You can treat them with Tylenol or ibuprofen in a little time. And what about the really severe side effects? We've all heard, and there are data to support, very rare heart problems, very rare muscle and nerve problems, all of which can occur. How often do they occur? Well, if you go into the heart problem, compared to the millions of doses, there have been 35 cases. So well under 1 in a million, well, maybe 2 in a million. For the muscle nerve Guillain-Barré kind of problem, there have been 4 or 5 cases. So yes, these can occur. They occur at a rate as equal to or less than the tetanus, the influenza, all of these vaccinations that you all get. So you can't say never, but basically, it's a reasonably safe thing compared to how good it is.
Thank you. Should a child who has high cholesterol get vaccinated for COVID?
Okay. I didn't answer the second part of the question is it safe to give to kidlets?
Yes.
Now, I'm not calling kidlets. Kidlets to me are 5-year-olds, okay? A 12 to 16-year-old, her physiology is essentially that of adults. And so it's as safe for them as it is for adults. At least all the data that exists seems to indicate that. For kids age 5 or even lower than 5, it's not the safety alone, but they can't figure out the right dose. For kids less than 5, is a half dose good enough? Well, it turned out it wasn't. They're having to go to a higher dose. For kids between 5 and 10, is a half dose good enough? It appears to be. So that the standard dose is going to be good enough because you're going to have a higher dose, but you know what the side effects are. I just talked about them. Are they worse for a 5 to 10-year-old? No, except they don't tolerate it as well. So you have to make some judgment calls on that. Can you give me the other question?
And so the same then for a little bit older, between 12 and 17?
Absolutely. For 12 to 17, their physiology is more like an adult than it is a kid. So they're probably at the same risk as adults and get the same kind of response as adults.
Thank you. I know that for IC people, 3 doses equals base vaccination and the booster is a 4th dose. I received the 2-dose Mrna series. And
hold it. What is an IC person?
I don't know. This is just the question I got.
I bet.
Go ahead.
Immune compromised. Okay. All right. So people on immunosuppressive drugs. Go ahead with the question again. Okay.
Okay. I know for IC people, 3 doses equal base vaccination and the booster is a 4th. I received the 2-dose Mrna series and booster, but might start a biologic. Does this mean I need a 3rd full dose? How do I time this dose?
Okay, so there are 14 questions involved in this. First of all, for immunocompromised people, the series is still 2 plus a booster. So it's not as if for immunocompromised people, 3 is the standard. So let's make sure we don't get things mixed up. Having said that, is a 4th dose the next booster Does it make sense? The answer is yes. With the provisos that I talked about before, okay? What was the second part of that question?
She says, does this mean I need a third full dose? And then the next one was, how do I time this dose?
Okay, so we talked about this before. It's as if you got your yearly influenza dose, right? So in my mind, and remember, I'm talking about not knowing the full data, a full fourth dose is the appropriate time dose. And the timing, based on the data I showed you, should be 5 to 7 months after the previous third dose.
Perfect. So this goes sort of into the next question, and you answered half of it. How do I suspend my medication? Is it a week before and after the vaccine?
Okay, this is in many ways drug dependent. So for example, a drug like Xeljanz, a week before and a week after is plenty. A drug like mycophenolate or Cellcept, 2 weeks before and after are plenty. A drug like rituximab, 6 to 9 months is what's needed.
Wow.
So it depends on the drug, but generally speaking, for most of the drugs that are not injected, 2 to 4 weeks before and after is sufficient. For the drugs that are injected, it depends on its half-life. So for example, I talked about rituximab, which has a very long half-life. You have to wait at least 6 months. If you are taking a drug like Actemra, then 4 to 6 weeks is sufficient before and after.
Thank you. I just noticed that I don't know if we actually answered the question about the cholesterol. A child who has high cholesterol, can they get vaccinated for COVID?
Yes.
Okay, thank you. How will we know when it's safe enough to go for a routine dental cleaning if we are immunosuppressed?
I'm not sure that has much to do with COVID. But I think that for people whose disease is going to flare without their drug, it should be continued and they need to be covered with antibiotic. But I don't want to go into that further. That's really off topic.
Agreed. Kind of a.
But just so you know, there are at least 13 questions waiting in chat.
Sure, I'm almost there. Do you think it's safe enough in Los Angeles area right now?
Safe enough for what? If you're going to go to a rave, the answer is no. Okay. If you're going to go and you're going to go out to dinner and you're going to go out and sit in the outside, the answer is yes. If you're going to go to a party with your friends, all of whom are vaccinated, and you're not going to be crowded into a room, the answer is probably yes. So, you know, common sense, folks. You don't want to get pushed to, in crowded areas where people you don't know are vaccinated or not are. But, you know, common sense. And I think that's what you're going to hear more and more of.
Okay, this is about addressing something called Evoshield. I don't know what this is. Who should get it? Is there a specific test that determines if you appropriately qualify for it? There's a but to it. You tell me how to break this down. Is it relevant if you've already had the 4th shot? Is there a time period to wait? Yeah.
So that's a nice, simple 30-minute talk. Having said that, Evoshield is a combination antibody that has been used and is available for most people who are at risk for getting COVID-19. So for example, a patient who's been on rituximab whose antibody response is negative after 1 or 2 months after the last dose of rituximab is a perfect person for such a drug. The problem is it's probably not as good as we'd like it to be against Omicron. It's pretty good against the others. Having said that, I certainly recommend it for people who have no antibody response after they've been vaccinated fully, and that they have to be aware that it's not going to cover all the variants.
Okay, thank you. You kind of went over some of this. Recommendation for fourth second booster in patients with SSC. So is that considered more of the fourth is a booster? It's not a full dose, Dr. Furst?
It's a good question, but it begins to be more a matter of, language. The fact is that the next booster or the next shot after the third, you can call it a booster or you can call it the next shot. And I do think, as I've said, we basically covered that. So let's go on to others.
Okay. He's also asking about switching from Mrna to Pfizer as an example.
And the answer is we've gone over that. And the answer is yes, you should.
Thank you. And I think you've already covered this one too. What is your on the fourth?
I feel badly for all the people in the chat. Can we switch over to it, please?
That's where we are right now, Dr.
Oh,
Furst.
great, great.
And remember, people sent these in to me ahead of time, which is why I had to go over them first. My rheumatologist, who is a scleral specialist, has been testing my antibodies and said to hold off on the fourth. Because she hasn't gotten the fourth vaccine yet. I'm not really sure what that question really means, Eva.
Let me try and answer it. My assumption is that whoever's speaking has adequate antibodies. If they have adequate antibodies, that is between 100 and 500 relative to baseline of 1, then they don't need protection. And that may be the reason the person is not recommending it. Okay?
Okay. I don't know what you mean by the IV, Demi. If I get COVID, would I ask for the tablets or the IV, which is best for scleroderma patients that have all 3 shots?
So the question has to do with Paxlovid versus molnupiravir versus the one I can't say, Sotrovimab. As you saw in the data, the Paxlovid and the Sotrovimab are about equal, and they are about equally effective. And so there's no need to get the IV if the Paxlovid is available. I can tell you that the Paxlovid has not been very available. But when it becomes available, you can go with that rather than the Sotrovimab.
Thank you. I think you've already answered this about the Evoshield. But she's saying, is it for pre-exposure prophylaxis for immunocompromised patients recommended? Is that the same as what you said?
Yeah, it's a great question though, because obviously you want to prevent it rather than treat it. And so in my view, if a person is at very high risk of getting bad disease, then trying to use it instead of vaccination, in essence, as a prophylaxis because the vaccination didn't work, kind of makes sense. And so, again, I go back to the example, the rituximab patient who has not manifested a antibody response despite the 3 or even 4 doses of vaccine is a perfect patient to give before they get COVID-19. How long does it last? Well, I don't know, 4 to 6 months. And you don't need it more frequently than that.
Thank you. I just had my 4th shot yesterday. What's the name of the antibody test I should get?
All right. Remember, you should wait 3 weeks, and the test you should get is antibody test, SAR-CoV-2 IgG spike protein titer.
Thank you. And remember, everybody, we're recording this, so you'll be able to take notes at your leisure once I send you the final. I guess you sort of went over this. I already had the 4th vaccination, Pfizer. Will I need to continue having these boosters?
The answer is, do you get boosted for influenza? If you get boosted for influenza, we're going to need to do this for SARS-CoV-2. I think it's just part of life. And the question is, how often? Is it every 6 months? Is it every year? How quickly can the can the vaccine be changed to the latest mutation, just like with influenza? So bottom line, that's part of life, just like influenza vaccination. And the frequency is going to be somewhere between 6 and 12 months, is my guess.
Thank you. So I know this is something you've kind of covered as well with the boosters and changing them. Do you have a preference, keeping up with the same one or switching, or does it matter?
I prefer switching.
Okay.
For the reasons you saw in the slides.
Thank you. Yes, Carl, you'll get a copy of that. If we continue, oh yeah, you basically said it. So switching, you're not saying one specific one over the other either, correct?
No, I do think that the J&J is less effective than the others. And although it's effective, it's just less effective. It's 77% versus 90% effective. So for the J&J, it's particularly important to get a 3rd dose with one of the mRNAs.
Thank you. Novavax is out now and Valneva is still to come. GSK and Sanofi announced a new protein-based vaccine, which is claimed to be 100% effective to avoid severe outcomes. What can we expect from those protein-based vaccines?
Okay. So it's a little complicated. If you think about this, the first time the mRNAs came out, they were 100% effective against death, and they still are. But that's not the real answer, is it? You want more information. You want to know, how good is it against hospitalization? How good is it against milder symptoms? And I think it would be wise to get those data from these new drugs. Now, the mRNA vaccine, just so you know, is a protein, just like these other proteins. So I think, although we don't have the data out yet, we have the data on these others. And I would be a little bit careful about jumping in to the latest drug out. But I anticipate that it's going to work very nicely. But we'll just have to see. So I just wouldn't jump onto that. And I don't think it's going to cause more or fewer side effects based on the information you just gave me. I need to know a lot more.
Thank you. I think we're going to have to end because we're almost, I'm going to ask one more question. It's great that there are so many effective treatments, but in reality, how available are they in the hospitals? What are the chances that COVID can trigger pulmonary fibrosis for those of us who don't currently have PF?
Okay, very good question. In fact, appropriate treatments in the larger hospitals are available for whatever you've got. Those treatments are there. The antibodies are there. The various drugs are there. I really think that you should feel reassured about that if you end up, God forbid, in the hospital. Now, I'm sorry, I lost the last part of that. What was that?
That was, can What are the chances that COVID can trigger pulmonary fibrosis for those of us that don't currently have it?
That's a scary one, folks. The answer is, if there's a lot of inflammation in a person who's got predisposition, you can get, at least theoretically, and I think probably, an increased possibility of getting fibrosis and damage to your lungs.
Thank you.
It's another reason to be fully vaccinated and to be careful.
Thank you. And I believe you already answered this. Methotrexate was in the group of maybe stopping it 2 weeks before, right?
Yeah, correct.
Okay.
Now, I've mentioned this before. The fact is that the methotrexate actually hangs around in the cells for a lot longer. But probably, you could say you don't have to stop at all. But I think just in general principles, stopping 2 weeks makes sense.
Okay. I think your thoughts on the safety for a teacher if students are allowed to not wear masks.
This is a tough one. I believe that the teachers are at significant risk. On the other hand, I can't tell you what to do if your principal threatens to fire you. And from a safety point of view, I think that unless the kids are protected, i.e. either masked, lots of ventilation, or vaccinated, they put the teachers at increased risk.
Thank you, Dr. Furst. How about I copy and paste the rest of the questions and I send them to you, Dr. Furst, and I can see if we can get some answers at a later time. And when I put out my recap with your slides, we can try to answer some of the questions because they keep coming in, but we're out of time.
Okay. Dave, nice to see you. Okay, folks, thank you for your patience. And I hope to do whatever you need to in the future. Take good care.